I want to welcome you all to our 2002 TAP Symposium. We are very excited to have you all here today with us. My name is Shannon Dyson, and I am the director for the Autism Program of Illinois, which we commonly refer to as TAP. Before we get started, I wanted to provide you with a brief overview of TAP so you know a little bit about us. And this TAP started about 20 years ago when Illinois parents, behavioral health professionals, psychiatrists, and public health officials began to express concerns regarding the prevalence of autism among children and the lack of available services throughout the state. So in 2003, the Illinois General Assembly responded to the outpouring of concern by establishing TAP as a state-funded grant provided by the Illinois Department of Human Services. Initially, the network was comprised of training centers at the University of Illinois at Chicago, Hope in Springfield, and at Southern Illinois University at Carbondale. The legislation was later amended in 2007 to require TAP to expand both training and direct services by deploying additional centers that would provide direct services to children with autism and their families. Today, the TAP Service Network is a collaboration of 4 universities and 11 organizations that together operate 20 centers across the state, which offer services that respond to the unique needs of communities across Illinois. TAP's function is to provide direct services to children and families in Illinois, increase the number of professionals trained to assess and provide evidence-based intervention for those diagnosed with autism, increase education of best practices among doctors, school systems, childcare providers, and the public, identify unmet needs and resources, and support research on better meeting the needs of those with an autism spectrum diagnosis. This is just a little bit about us, but we'll continue sharing information about TAP in our videos during break times. Let us know if you have any questions or want to learn more about what we do. Just some general housekeeping items before we get started. Throughout the presentations and at the end of the symposium today, we'll share a link to fill out a survey. We ask if you can take just a few minutes to fill that out. That would be greatly appreciated. Just lets us know how we're doing and to make sure that we're providing content that is of interest to you. If you have any questions during the presentations, please enter them in the Q&A box. And we'll address these questions at the end of each presentation. We'll save a little time and we'll try to get to all of them if we can. Once again, I want to thank you very much for joining us today. We're excited that we can offer this training opportunity with such an outstanding lineup of speakers. So with that, I would love to introduce our keynote speaker, Dr. Wayne Fisher, who's the inaugural director of the Rutgers University Center for Autism Research, Education, and Service, a board-certified behavior analyst at the doctorate level, and a licensed psychologist. He was previously a tenured professor at the University of Nebraska Center and the Johns Hopkins University School of Medicine, and the Kennedy Krieger Institute, which he built clinical research programs in autism and developmental disabilities with international reputations for excellence. He has published over 200 peer-reviewed papers in international or for 30 different behavioral and or medical journals, and has near continuous federal grant support for his research for over 20 years. Today, he's going to be talking to us about recent advances in the functional analysis and treatment of severe destructive behavior. All right, so Dr. Fisher, I'm going to let you take it away from here.
Thank you so much for that kind introduction. It's great to be here, and it's great to hear about TAP. It's wonderful to see such coordinated services across the state. It sounds like it should be a model for many places. I'd like to also thank my clinical and research staff for the work they've done. I get to come up and present and get all the credit, and they do all the hard work that make the research and advances possible. And just as a brief introduction, probably no new information here for you, but in terms of what is autism, it was once thought to be a form of schizophrenia, but it differs from schizophrenia in all of the factors that make up a syndrome, including the symptoms, age of onset, family history, etiology, and response to treatment. We define it in terms of markedly impaired development in social interaction and communication, along with restricted repertoires of activities and interests. And the symptoms and severity vary greatly across children. It is estimates are 1 in 59 children. That's kind of a moving target. In New Jersey, we're down around 1 in 35, and that's kind of in line with more systematic prevalence studies where they look at an entire population, screen the entire population, and then go in and do diagnoses. As you know, it's 4 times more prevalent in boys than girls, and the prevalence has been growing yearly, somewhere around 5 to 15%. It also tends to run in families. If an older sibling has ASD, the risk for a younger brother is as much as 1 in 4, and for a younger sister, about 1 in 11. In terms of what causes autism, it is a variety of things. Genetics plays a very important role, but yet there is no single genetic condition that accounts for even a small percentage of the individuals with autism. There are epigenetic factors and also non-genetic factors. There is no medical test for diagnosing autism. We do it based on interviews and observation. There are important tools that we use for screening for autism. I won't go into details on those. And there is a fairly substantial and growing number of empirically supported treatments for autism, including early intensive behavioral intervention, parent training, applied behavior analysis for co-occurring behavior disorders such as aggression and self-injury, and that will be the focus of my talk today. Cognitive behavioral treatments have been shown to be effective for anxiety and higher functioning individuals with autism. Social skills training also has pretty good support. There are a couple of medications that have been shown to be effective in randomized clinical trials, aripiprazole and risperidone. Melatonin is helpful for initial insomnia. And then there are a number of other medications that are used on a kind of targeted, symptom-targeted basis. So if an individual with ASD presents with hyperactivity, inattention, impulsivity, then there probably is a higher chance that a stimulant medication might be beneficial for that individual. But the response in children with ASD tends to be much more idiosyncratic. And so it's very important that we work collaboratively with psychiatrists and developmental pediatricians to provide good data on whether a medication is working or not working. And then there are a number of off-label uses. And again, these are typically on a symptom basis. So if an individual shares symptoms with a condition like OCD or anxiety or depression, then serotonin reuptake inhibitors may be helpful. When we compare the amount that's spent on research for autism, it is much more common than many other conditions, but many fewer dollars are spent on autism. And so this just shows the prevalence of autism in relation to juvenile diabetes, muscular dystrophy, leukemia, and cystic fibrosis. But when we look at the amount spent on autism on a per case basis, autism is way down at the bottom. So there is still much more to be done on improving and funding research for autism. So on to autism and problem behavior. The scope of the problem in autism is hard to define precisely because it depends on what you define as problem behavior and then how serious it is. If one looks broadly and includes these problem behaviors, feeding problems, sleeping problems, tantrums, self-injurious and aggression, and one looks over kind of a lifetime, almost all children experience one or more of these. And this is just a graph from that study showing how many, the percentage of children that have 0, 1, 2, up to all 5 of these behavior problems. And then the comparison is between children with language impairment, the HLI, which what you see is the majority have 0, and then it goes down from there. And then the histogram of the distribution is shifted for the children with autism, where the highest number is most children with ASD have at least 2 of these, followed by 3, and then it goes down in each direction from there. There are a number of variables that are associated with problem behavior in children with autism, including lower IQ scores, lower expressive language scores, increased social deficits, and there are others as well. The cost-benefit analysis for treating severe destructive behavior, and again, we're not talking about that 98% of children, but those that have the most severe forms of destructive behavior. And then the prevalence rate goes down somewhere around 6 to 10%. But these children who are hurting themselves, hurting others, or destroying property, the annual cost, the cost over a lifetime can be $8 million or more. And if we can keep just one child out of chronic care because of their behavior disorders, that effective treatment and prevention of long-term care can pay for the treatment for hundreds of more children. And the treatment approach I'll be talking about today has over a 90% success rate. And to give you an example of the potential cost savings, this is from a young man that I worked with first as a postdoc and then as a faculty member at the Kennedy Krieger Institute. And when he first came to us, he had bruises up and down his body from his self-injurious behavior. His mother was similarly bruised from his aggressive behavior. He threw television sets and microwaves and put lots of holes in the walls. And when he came to us, he was approved for residential treatment program, but there was no bed available. And so we began working with him first on an outpatient basis, and then also on an inpatient basis. He had 2 relatively short inpatient stays. And to get his behavior under really good control, the cost, and this is calculated in 1996 dollars, I believe, was about $86,000. And if I just told you it cost $86,000 to provide behavioral treatment for one individual, you'd say that's incredibly expensive. But if you compare it to the cost of going into residential treatment, and he was somebody with his behavior, had he gone into residential treatment, he would have spent the rest of his life in that treatment. We saved well over $6 million in treating this one individual. I have on occasion gotten calls or emails from his mother. He's an adult now. The last time, it's been probably 10 years since I've heard from him, and the last concern she had was that he was interested in girls, and I thought that was about time for that. So To give you an idea of the level of severity of behavior we see, these are some of the most severe cases, even for the programs that I've worked with. This is a young woman who came to the neurobehavioral unit at Kennedy Krieger Institute. And on the first day of her admission, she hit her head or banged her head against objects 20,932 times. We know that because we count all of the behavior that's going on during the day. And as you can see you see her right ear up here, and she has cauliflower, what's called cauliflower ears, lots of scar tissue there. She has scar tissue across her head. Her nose is actually widened from the banging she'd done there, causing scar tissue. And she's a rather unique case, and kind of what I say is the exception that helps to prove the rule, is that she's the only individual I've seen in my entire career that dates back several 100,000 years. I've been doing this a long time, that we could not find any situation in which she had low levels of behavior. That is, across all situations, all contexts, she was engaging in high rates of self-injurious behavior. Here's a much different presentation. This was a young lady with Cornelia de Lange syndrome, and she would go weeks at a time with no self-injurious behavior. And then she would have an episode that we thought was a manic-like episode where we'd see increased vocalizations. She was nonverbal, but would make kind of stereotypic sounds almost constantly during this period. She was very hyperactive. We saw decreased sleep. But the most concerning problem we saw during these episodes was that she would seek out and bang her head against hard objects. And what you see here is what she did by banging her head against the faucet on the tub in her home. And as bad as that looks on the outside, if you look up at the top of this X-ray, you can see that she was compromising her skull. And had she broken through, obviously the risk of brain damage and even death from that. And I'd like to show a short video. And I like to show this video because it was made by the parents of this child as a before and after tape, and they did it without telling us about it, but then gave it to us once they'd done that.
This video shows Dylan, a 7-year-old with autism and severe self-injurious behavior. The video was made by Dylan's parents to show how severe behavior disorders negatively impact the child and his or her family, and also show how effective treatment can dramatically improve their lives. Dylan was literally attached to his mother all of the time. She couldn't put him down to go to the bathroom or even to go to sleep. They were physically attached like this because whenever she put him down, he engaged in self-injurious behavior. As an example, she is now going to try and put him down for a few minutes so she can make lunch. As you can see, he immediately displays severe self-injurious behavior.
A general idea of what he does. This is typical behavior. A lot of times I do sit him in the chair, but he just continues to hit himself and kick and slap and stuff. These are holes in the walls that Dylan just did recently.
These are hard plastic walls, and Dylan has to bang his head exceedingly hard to produce these holes. Head banging of this intensity over time can result in brain damage or detached retinas and blindness. This scene shows how these destructive behaviors affect not only Dylan and his mother, but also the other members of the family. Dylan's brother is at an age where at this time of the morning he might typically be watching cartoons while he waits for the school bus to come. Instead, he is asked to restrain Dylan to help prevent the self-injurious behavior. This scene is the same as the beginning scene, except that Dylan has now undergone 3 months of intensive treatment, and his parents have been trained to implement the treatment. Mom's about to make lunch. Before she does, she puts out a card to signal to Dylan that he can have her attention, but for appropriate behavior. Dylan doesn't speak, so he hands a card to his mother that shows he and his mother playing together. Now, rather than holding on to him and attending to him all day long, she gives him 1 minute of high-quality attention.
That's Dylan's big ball? That's Dylan's big ball? Yeah. Dylan's big ball. Oh, you're down.
Dylan is about to gesture to his mother with his left hand that he wants her to go to the play area with him. There he goes. Now Mom will signal back and tell Dylan that he has to wait.
Hey Dylan, you have to wait.
And now Dylan is able to separate from his mother and go and play independently while his mother makes lunch, something he was never able to do before treatment.
So the process that we went through with Dylan is fairly typical. And the first kind of thing we do is our functional analyses to try and understand why the behavior's occurring. And for Dylan, it wasn't too difficult to figure out that the function or purpose of his behavior was to gain and maintain adult attention, preferably his mother, but if she wasn't there, whoever was around. And our functional analyses confirmed that. And once we had that information, we then initiated functional communication training where we taught Dylan that SIB no longer resulted in attention, but that he could get attention through an appropriate communication response. And we taught Dylan to hand over a picture card that showed a picture of him and an adult playing together. And initially, the card worked like magic. So every time he wanted attention, he handed it over, he immediately got attention. And that reduced his SIB to near zero levels. And we had high rates of the communication response, but it wasn't a treatment that was practical to implement at home for his mother or in the school because he was demanding constant attention. So the next thing we did was to teach Dylan that you can't always get what you want. And we did that through a variety of procedures. We played the Rolling Stones song, "You Can't Always Get What You Want." Everybody enjoyed that, but it didn't have much of an effect on Dylan's behavior. So the most important thing that we did was the card that he used to exchange to get attention. We started putting it away for short periods of time, a few seconds, then brought it out, he could get attention. And then gradually we extended the period of time that attention was unavailable, where the card was away. And we did that over time to a point where when he was discharged, the card came out once every 15 to 30 minutes, and he could exchange it for 1 minute of high quality attention. And that was a schedule of reinforcement that his mother could practically do in the home. And he was in a special education classroom where they could do that schedule at school. And that was a procedure that was both effective and practical. Okay, so I had a couple of comments on my slides. I'm going to go forward with the slides. All right, can folks see the slides okay? All right. Great, thanks. Just having a little bit of difficulty with advancing the slides now. There we go. So in our programs, we collect data, usually on laptop computers, and everything is quantified and measured precisely. All the behaviors that we're targeting, both for decreasing and for increasing. We define precisely and measure precisely. And our goal is to design interventions that are both effective and practical. And for that, we try to follow Einstein's recommendation of making everything as simple as possible, but not simpler, meaning make it as simple as you can as long as it is effective, but you have to make sure that it's going to be effective. We take what's called a functional approach, and it differs from typical ways of diagnosing behavior disorders. With a structural approach, we look at how often a particular set of symptoms or responses cluster or co-vary. So with the diagnosis of autism, we see impairments in social communication and repetitive restrictive behaviors. But just knowing those symptoms and knowing that diagnosis doesn't really tell us where to begin to intervene. We need much more specific behavior, specific data on the target responses. And with a functional approach, we're looking more specifically at those target behaviors and looking at whether and which environmental variables influence the response. And the common functions of self-injurious behavior or other target behaviors are social positive reinforcement in the form of attention, such as the case with Dylan, or tangible items, gaining access to an iPad or other things. Social negative reinforcement in terms of escape from non-preferred demands, or automatic reinforcement, where the behavior produces its reinforcement in the form of sensory or other forms of stimulation automatically. Once we understand the function of an individual's behavior, problem behavior, we then have a number of potential function-based treatments that we may implement, such as providing the functional reinforcer for an appropriate alternative response, such as functional communication training, where we teach a communication response, or differential reinforcement of compliance. We may provide a competing reinforcer, that is to try to understand what are other effective reinforcers that are not associated with problem behavior, but that can be delivered when the functional reinforcer is not available. Removing the establishing operation for problem behavior. The establishing operation are the environmental contexts that are motivating the problem behavior. So for behavior maintained by attention, if a child hasn't received attention in a while, that should increase motivation for getting attention, and it may call forth behaviors that have produced attention in the past, such as self-injurious behavior. And so if we can control that EO and make sure that the individual is getting reinforcement on a regular schedule, that may reduce problem behavior. Removing the reinforcement contingency for problem behavior, what we call extinction, is really important. And then for some individuals, removing the functional reinforcer contingent on problem behavior, which would be a punishment contingency, may be helpful. We rarely use punishment. The most common situation where we do is we sometimes see an individual say their behavior is maintained by tangible reinforcement, access to an iPad, and it's not uncommon for the individual to use their communication response, say iPad please, or hand over a picture card, get the reinforcer, and before the EO has gone away, before their motivation goes down because they start engaging with the iPad, they may haul off and hit the therapist. And we found that simply removing the iPad contingent on that behavior, having them again emit their functional communication response before getting it back, can be very effective at eliminating that problem behavior that may otherwise persist. Okay, so I'm going to be focusing mostly on functional communication training, where we're replacing problem behavior with an appropriate alternative response. And FCT involves the reinforcement of a very specific appropriate communication response, a communication response with which the individual can request the reinforcer that previously maintained problem behavior. And FCT has been used to treat a wide variety of problem behaviors: aggression, self-injury, inappropriate vocalizations, kids that don't share with siblings, just a really wide variety. It is, again, prescribed based on the results of a functional analysis. We typically also place problem behavior on extinction. And the reinforcer for problem behavior is used to reinforce the appropriate communication response. That's basically the same idea. It's used to reinforce an appropriate response, and examples might be for a child who is engaging in problem behavior that's maintained by escape from non-preferred tasks. We may teach them to request a break by signing finish or saying break please. And so what it looks like is, if we have a child whose problem behavior is maintained by aggression, in the functional analysis, we analyze the contingency that says that aggression produces tangible reinforcement. And then we break that contingency and teach them that aggression no longer produces reinforcement, and teach them that they can gain that reinforcer through an appropriate alternative response. And what the training typically looks like is this.
This video shows one of our therapists conducting the initial training to teach a child to touch a card as the FCT response. On the first trial, she takes the iPad away, then immediately guides the FCT response, and then reinforces the card touch by immediately returning the iPad. After multiple trials of this type, the therapist then inserts a brief delay between the removal of the reinforcer and the prompt to touch the FCT card. Over time, the delay is lengthened until the child is consistently touching the FCT card independently without any guidance by the therapist.
Okay, once we have taught the FCT response, again, the common issue is that the individual requests reinforcement near continuously, that if the behavior is maintained by attention, they demand constant attention. If it's maintained by a tangible reinforcer, they request the tangible reinforcer over and over again. If it's maintained by escape from non-preferred tasks, they may request to escape or get out of every school task, every chore around the house, and that's simply not reasonable for the individual. It's not reasonable for the parent that we may ask to implement the procedures. So typically we want to thin the schedule of reinforcement to make it more practical and easier for caregivers to implement. There are a variety of procedures that have been designed to help with schedule thinning, signaled and unsignaled delays, activities or alternative reinforcers during the reinforcer delay. So if an individual is engaging in problem behavior to get attention, and there's going to be a long period where attention is not going to be available, such as in Dylan's case, where mom is going to be engaged making lunch, then having some alternative activities such as preferred toys. If a child likes certain movies or watching certain shows, that would be a time to present that to help compete and help the child tolerate that period where attention is going to be unavailable for an extended period. And what we've used the most, and sometimes combined with these others, are multiple schedules of reinforcement, where we signal when reinforcement is available and when it is not available. And so we bring the FCR into the control of the discriminative stimuli, and typically we will gradually lengthen the duration of the extinction component to achieve our desired outcome. A typical one we start with is starting out with very short periods of reinforcement and extinction, and then getting to a point where the individual is waiting 4 to 8, 5 to 10 minutes without reinforcement consistently. In our first study on using multiple schedules, we didn't do that second component. We signaled the availability of reinforcement with a card was hung on the wall, and when it was removed, reinforcement was unavailable. And this procedure reduced reinforcement by about reinforcement time by about 50%. This is one of the cases from that individual. You see high rates of problem behavior, destructive behavior, and baseline. We both did alternative. This was an individual whose behavior was maintained by attention. And so access to detention occurred according to the multiple schedule in the open circles. Access to toys was available in the closed circles. And this bottom graph shows communication. And what you see is the individual starts correctly requesting reinforcement when we signal that it's available. And these are incorrect requests or requesting reinforcement when we signal that it's unavailable. And so you see that both the alternative reinforcers and the functional reinforcers reduce destructive behavior to low levels, and the individual learned to only request reinforcement when we signaled that it was available. The Hanley study was the next important thing in the development of multiple schedules, where he added the component of gradual schedule fading. And so a typical schedule started out with 45 seconds of reinforcement, alternating with 15 seconds of reinforcement being unavailable, signaling its unavailability, and then gradually extending the duration of the extinction component until you have about a minute of reinforcement, followed by 5 minutes of, or 4 minutes where reinforcement is unavailable. And sometimes you had back-to-back extinction components, so that would be 8 minutes without reinforcement. And we really try to tailor the final schedule based on the individual's environment. So if someone's in high school and they're going back to a situation where they need to go 30, 45 minutes, even an hour without reinforcement, we do our darndest to come up with a schedule that's going to fit with that whenever possible. Okay, so the teaching of the multiple schedule FCR looks like this.
As you watch this video, you will see that the therapist is wearing a lanyard that is green on one side and red on the other. The therapist will periodically switch the lanyard back and forth between the green and red sides. When the red side is showing, it signals to the child that the iPad is unavailable. When the green side is showing, it signals to the child that he can get the iPad by requesting it with the FCT response. We continue this training until the child is consistently requesting the reinforcer when the green side signals that it is available, and also until the child is not requesting the reinforcer when the red side signals that it is unavailable. After that, we begin to lengthen the periods in which the red side signals the unavailability of the reinforcer. For some children, we can do this rapidly, and for other children, we have to lengthen the red periods in a series of small steps.
Our goal is typically to train the child to tolerate delays where the functional reinforcer is unavailable for at least 5 minutes. Once we reach that point, most children are able to disengage with the toy and move on to some other activity.
Okay, so I had a question about whether the video would be available, and I'm more than happy to try and make that happen. I don't think that's something that we had planned on. I did share the slides with with Shannon, and I'm more than happy that anybody that wants copies of the slides, typically we share those in a PDF format just to make it easier to share, because the videos take up a lot of space and don't do well with emails. But I'm more than happy to work with folks to try and make those available. Okay, so that's kind of the basic introduction to FCT. And now what I'd like to do is to focus a little bit more on what we're doing now in terms of the recent advancements and refinements that we're working on, because things don't always work out perfectly. For example, as I looked at that video, if I was redoing it, one of the things I would put in is that now we typically do just a simple color matching task with children to make sure that they don't have color blindness. So we don't use the red and green cards if we have them do matching and they are not clearly discriminating between red and green cards. And a number of other things that can go wrong during FCT. We're really trying to understand those, research those, and to work in those. And so our focus is on our three major components of function-based treatments, and those are the differential reinforcement of appropriate behavior, extinction of problem behavior, and then typically we introduce these treatments into a specific context. In our case, we do this with individuals with real severe behavior. So we have specialized treatment rooms with padded walls and floors. And so it's a very unique context that allows us to observe the behavior and keep everybody safe while we're doing that, which is important. But then that also can affect how well the treatment's going to work once we generalize it to other contexts that are not similar to our very specific context. And so that's what I'll be focusing on now. And the first thing that we have been really working on lately is why do we see extinction bursts with some individuals? And extinction bursts, we believe, occur when we switch from baseline, where the problem behavior, destructive behavior produces reinforcement very predictably and very consistently, and then we switch and teach an alternative response and introduce extinction. And for some individuals, they don't learn to produce reinforcement as consistently and as efficiently as they did in baseline, and they experience a drop in reinforcement. And we believe that this drop in reinforcement sets the occasion for extinction bursts. And I'll go into more detail in explaining that. A second problem that we see is that sometimes after successful treatment, the alternative response becomes less effective at producing reinforcement. And we may see resurgence or relapse, treatment relapse, resurgence of problem behavior, an increase in problem behavior, and that's called resurgence. And then finally, when we introduce treatment in one context, such as our clinic, and then subsequently transfer the treatment to another context, such as the patient's home or school, we may see an increase in problem behavior. And when we see an increase in problem behavior that's due to a context change, we call that renewal. And this can occur even if the treatment is implemented with pristine integrity. That is, the teachers, the parents, they're doing it all correctly. We still may see an increase in problem behavior. And so we've been working on ways to help deal with these types of limitations and problems with FCT. And Tony Nevin and Dave Wacker noted that treatment effectiveness and durability is usually tested under optimal conditions in the research literature. So a place like the Neurobehavioral Unit at the Kennedy Krieger Institute or our program. And they suggest that we really should be testing treatment durability by challenging it under suboptimal conditions. We want to make sure that the treatment is also going to work in those suboptimal situations. And we should continue to work at our treatment until it passes those tests of suboptimal conditions, such as tests of resurgence, tests of renewal, etc. And so that will be a part of my discussion today, is how we do that and what may help under those suboptimal situations. Okay, so what is an extinction burst? Typically, it's defined as a temporary increase in responding when extinction is introduced to levels higher than those displayed when reinforcement was in effect. And probably the best known definition and most used one is by Lerman and Nawada, where target response rates in one or more of the first 3 treatment sessions increase to levels higher than all of the last 5 or all of the baseline sessions. And so what that looks like is what you see here is in baseline. We have destructive behavior here, sessions here, and all 6 of these data points are at or below 2.5 destructive responses per minute. And what we see here is in this second treatment phase, we see destructive responses going up to about 3 per minute. And so that is higher than all of these last 5, in this case there's 6, but the last 5 data points, we would consider that an extinction burst. Extinction bursts can also materialize in the form of increased variability or more responses, or even increased intensity of responses. But typically, we define it and measure it in terms of an increase in the rate of responses. And why is it important to understand and study these? Well, extinction bursts can result in increased harm to self, others, or the environment. And also, caregivers may discontinue a treatment when destructive behavior increases. And currently, our major procedure for dealing with extinction bursts is to prepare the caregivers that this might happen. We tell parents that things may get worse before they get better. And we hope that by telling them this, that will mean that they will stick with the treatment even if behavior gets worse. But the little data we have suggests that that is typically not the case, that is not a very effective intervention for dealing with extinction bursts, simply telling parents that this may happen. Okay, so our working hypothesis for preventing extinction bursts is that we need to avoid drops in reinforcer access time when we introduce treatment. That is, we want to make sure that the individual continues to receive reinforcement at or above the level they received it during baseline. And drops in reinforcement may occur when we introduce treatments like FCT if the alternative response is not well established, okay? Because if the individual isn't using the functional communication response, they're not gaining access to the reinforcer, and the amount of exposure to the establishing operation then increases. And it can also occur due to changeover delays. What's a changeover delay? Well, when we have an individual display an appropriate communication response, say handing over a card, we want to reinforce that. And when they engage in, say, SIB, we don't want to reinforce that. Well, sometimes what we see is the individual both does the old behavior and it doesn't work, and so they immediately then try the new behavior. And what may happen under those situations is the individual may start chaining, hitting, then handing over the card, and that makes it very hard to get the problem behavior to come down. And so what we do is what's called a changeover delay, is we only reinforce that handing over the card if no problem behavior, no SIB in this case, occurs for at least 3 seconds before they hand over the card. And such a changeover delay, if the individual does this, hands over the card, does this, hands over the card, again, we may have a longer period of time where they go without access to reinforcement, and that may increase the likelihood of an extinction burst. And so here's one of the first studies we've done on this topic. And we had two conditions that we compared. One was the limited EO condition, where we really tried to prevent a drop in reinforcement. And then we had the extended EO condition that allowed a drop in reinforcement. And we compared these two conditions and looked at rates of how well they reduced problem behavior, and then whether or not an extinction burst occurred. And so here's the data from Corbin, one of the individuals in this study, and you can see he has self-injurious behavior listed along the y-axis and sessions along the x-axis, fairly stable rates of self-injurious behavior in baseline. We then introduced treatment, and so in the limited EO condition, we had a 0-second delay. So what that looked like was Corbin was playing with the iPad. We removed it, immediately guided him to touch it, and then immediately returned that. And we did that as absolutely as quickly as we could to really prevent any sort of period of time where reinforcement was not available. And we compared that with the extended EO condition. And for Corbin, this was just a 5-second delay, which is a fairly typical delay that's used when training functional communication responses, where we give the individual, after removing the reinforcer, we give them 5 seconds to emit the target communication response independently. And for Corbin, that looked like this. So we had he was playing with the iPad, we removed it, started the 5-second delay. If he didn't engage in behavior independently, we guided it to him and then returned it. So this wasn't an abnormal situation. This is a fairly common thing that you see in the literature. But for Corbin, just that 5-second period was enough to produce an extinction burst. And here's what that looked like. Again, after stable baseline rates, we see in our limited EO condition, destructive behavior very rapidly decreasing to near zero levels. In our extended EO condition, we have extinction bursts in all three of the first 3 sessions. We go back to baseline and get similar rates, a little bit lower, but similar rates, and then go back to our 2 treatment conditions. And again, very rapid reductions to low levels in the limited EO context, and then an extinction burst in the 3rd session in the extended EO condition. Okay, so one of the things in the extinction burst literature that we're seeing is that there's a kind of inconsistency or discrepancy between what's being reported in some of the basic studies and what we see in the clinical studies. So Littell and colleagues have done a couple of investigations recently and found very little or inconsistent evidence for extinction bursts, and that typically only occurred during the first minute of extinction, and no pigeon or rat in either study met the Renewal criteria for an extinction burst. And this was under just not having differential reinforcement, just going from a reinforcement of problem behavior baseline to extinction. And under similar conditions, clinical conditions, Lerman found that 62% of individuals with intellectual disability exposed to extinction alone met their criteria for an extinction burst. So pretty big discrepancy. And we think there are 2 major reasons for this. One is that basic researchers tend to remove reinforcement time when calculating response rates, whereas clinical researchers typically do not. And clinical researchers typically program denser schedules of reinforcement in baseline than basic researchers. So for example, an FR1 schedule for a clinical case is pretty typical. A VI 1-minute schedule might be very typical for a basic researcher. And the other thing related to this is if we're providing reinforcement in the form of access to toys, typically the reinforcement interval is fairly long compared to basic researchers, whereas in a clinical study, we may deliver the iPad for 20 to 30 seconds. In a basic study, the individual has 3 or 4 seconds access to, say, the feeding hopper. So why is this important? Well, there's several reasons, and I'll go over. The first one is just how we do the calculations. In a typical 5-minute baseline session in a clinical study, destructive behavior might produce access to an iPad for 20 seconds. So an efficient individual might emit 12 destructive responses and produce about 4 minutes of reinforcement time. And the other 1 minute of the 5-minute session would be without reinforcement time. So if in that situation, we move to extinction and we see 24 destructive responses during the 5 minutes without any reinforcement, we would produce rates this way, depending on how we calculated it. So baseline rate of 12 per minute, 12 responses divided by 1 minute when we exclude reinforcement time. So that would make the response rate very, very high. And that is typically what might be done in a basic study. In a clinical study where we calculated on the whole session time, we would have 12 responses divided by the full 5 minutes of the session when one includes reinforcement time. That would produce a rate of 2.4. If in treatment, we go to extinction and we have 24 responses, we would divide that by 5 minutes because there's no reinforcement time. So when we compare 12 with 4.8, we have a reduction in responding and no extinction burst. But when we include reinforcement time, we go from 2.4 to 4.8, and that would be an extinction burst. So the calculation method is really important. And it's also important just from a social validity standpoint. So an increase from 12 destructive responses in a 5-minute baseline session to 24 destructive responses in a 5-minute treatment session is clinically significant. And especially if you consider, that the individual may do more harm as a result of twice as many self-injurious responses. And also it may increase the likelihood that the parent is going to stop implementing the treatment. That makes this a clinically significant phenomenon. So we think that it's important to keep reinforcement time in the equation from a social validity standpoint, but it also may be important in understanding extinction bursts. And we have been applying the matching law, a revised version of the matching law, to better understand extinction bursts. And so conceptually, we think of the time in a session between when the reinforcer is available and the reinforcer is unavailable during the inter-reinforcement intervals. And during those intervals where reinforcement is not available, the individual has two response options that we program. One is they can engage in self-injurious behavior, or 2, they can engage in the functional communication response. And then during reinforcer intervals, they essentially have a third option. While those reinforcer is available, they can still engage in SIB, they could still engage in the functional communication response, or they could engage with the reinforcer and consume the reinforcer. And so our hypotheses are that during the reinforcement interval, individuals can consistently choose reinforcer engagement. During inter-reinforcement intervals, individuals choose the FCR over SIB once they've learned that the FCR produces reinforcement and SIB no longer does. But until they learn that new contingency, they may repeatedly choose SIB over the FCR, thereby producing an extinction burst. And so this figure shows the within session patterns of SIB and reinforcer engagement in relation to session time and reinforcement intervals. So we have baseline in the top timeline and FCT in the bottom timeline, typical FCT session from the extended EO condition for Corbin. And we have occurrences of SIB demarcated by the tick marks, reinforcer intervals where reinforcer is available by the black bars, and then reinforcer engagement, whether they're actually consuming the reinforcer with the shaded bars. And so what you see is in baseline, basically what happens is Corbin would engage in one SIB, and then for the rest of the reinforcement interval would then engage with the reinforcer. And this pattern held pretty much throughout the session. But when you look at FCT, where what we're seeing is bigger gaps between the reinforcer intervals because he hasn't learned to independently request reinforcement, is you see during that gap, that extended gap where the reinforcer is not available, you're seeing repeated occurrences of SIB, and that is in essence the extinction burst. And so these data are very, very consistent with our hypothesis that the individual is essentially choosing reinforcement when it's available, and then choosing SIB over the functional communication response, in this case, because he's not yet learned the new contingency and not yet learned that SIB no longer produces reinforcement. And these data illustrate that examining the within session patterns of target and alternative responses in relation to reinforcer availability and consumption can help explain when and why extinction bursts occur, and especially using the definition provided by Lerman and Iwata. Okay, so on to renewal. Renewal is the recovery of behavior that occurs when the individual is exposed to a change in context after the target response has decreased to low levels in the original treatment context. And so how that looks with FCT is we have high rates of behavior in context A, which could be the child's home in baseline. We introduce treatment in context B and get a nice reduction to low levels. And then we want to transfer the treatment back to the home situation, A, or even to a new one, C, maybe the school. And if by just changing the context, we get an increase in problem behavior, that would be an example of treatment renewal. And our working hypothesis for preventing renewal is that establishing strong discriminative control of the functional communication response and destructive behavior can help prevent renewal when we transfer treatment from one context to another. In this paper, we looked at whether signaling periods of reinforcement and extinction using our multiple schedule can facilitate transfer of the treatment from one context to another without renewal of destructive behavior. And we did this across a variety of therapists and settings from one room to another. And we, in most cases, we went from a multiple schedule 60-60 to our final schedule. And in our treatment context, we provided the discriminative signals, the lanyards, which signaled when reinforcement was available, the green SD, or when reinforcement was unavailable, the red S delta. I'm just going to show you one case in this. And so we have baseline in our first context, and we introduce, so destructive behaviors producing reinforcement, and on an FR1, the FCRs are on extinction. We then introduce our multiple schedule with 60 seconds of reinforcement alternating with 60 seconds of extinction. And what you see is we get a nice increase in the individual requesting reinforcement when it's available. The open triangles are requesting reinforcement when it's unavailable. There's destructive behavior. What you see is it takes about 5 sessions to reduce behavior to our target criterion. That's where this asterisk is, where we have high levels of requesting reinforcement when we signal it's available, low levels when we signal that it's unavailable, and low levels of destructive behavior. And so now we transfer the treatment to room C, and we reach that same criterion now in just 3 sessions and no renewal of problem behavior when we introduce a treatment in a new context. And we then go to our room A, our third context, and now we reach that terminal criteria in the very first session. So having the signals present facilitated the transfer of treatment. Our treatment resulted in rapid transfer of FCT treatment effects across therapists without renewal of problem behavior. Sorry. Moving on to Resurgence. Resurgence is another form of treatment relapse, and it involves the recovery of problem behavior that occurs following treatment with alternative reinforcement plus extinction when the reinforcement conditions produced through alternative responding worsen, such as when the alternative response is placed on extinction, which might happen when a parent fails to reinforce the appropriate response because the parent is changing an infant sibling. So what that looks like is we have reinforcement of problem behavior in baseline. We then introduce extinction of problem behavior and reinforcement of the alternative communication response. And again, get a nice drop in behavior. But in this third condition, we have extinction without alternative reinforcement. That is, this is sometimes called an extinction challenge, where now both the alternative response and problem behavior are on extinction. And if we see an increase in problem behavior during such an extinction challenge, that is referred to as resurgence. And the clinical risks from resurgence are, again, we may get an increase in problem behavior, which may cause harm to self, others, or the environment, or caregivers may stop implementing the treatment and resume baseline contingencies when resurgence occurs. Our work on preventing resurgence has been informed by behavioral momentum theory, which makes several specific predictions of how to prevent or mitigate resurgence of destructive behavior. We've been using Nevin and Shahan's equation 7, and I won't go through the mathematics of that in any detail, but I'll just show you what the symbols stand for and what they mean. So in this case, this is time in treatment, and the equation predicts that more time in treatment should result in less resurgence. So if we have the treatment in place for a longer period of time before we introduce an extinction challenge, that should help mitigate resurgence. And our research thus far has not provided much support for this hypothesis. The equation also predicts that reducing the rate of reinforcement for destructive behavior for the alternative response during treatment should help reduce resurgence. And we found some but variable support for this hypothesis. And finally, the equation also predicts that reducing the rate of this is the one for alternative reinforcement. The rate of reinforcement for the alternative response during treatment should reduce resurgence, and our results thus far on this have also been fairly mixed. So what I'm going to show you in terms of data today is that the model predicts that simultaneously making all of these changes, that is increasing the amount of time in treatment, reducing reinforcement for the problem behavior during baseline, and reducing the rate of reinforcement for the alternative response during treatment. If we do all of those things, that should produce the largest reductions in resurgence of problem behavior during an extinction challenge or resurgence test. And so that's what we did in this study. And these are hypothetical data generated by the model. And so that's one neat thing about quantitative models, is you can kind of do what if, what would the data look like if the model is correct? And so these are our test and control conditions. So the control condition are the dark circles. So we have a high rate of reinforcement, low rate of reinforcement for our test condition. During treatment, we do 3 times as many treatment sessions in our test condition as our control condition, and we lower the rate of reinforcement significantly in comparison to our test condition. And what the model predicts is a high rate of resurgence in our control condition and a much lower rate in our test condition. And so now I'll show you some actual data. This is from one of the participants. And again, our lean lung condition is our test condition. The dark circle is our control condition. And basically what you see is both treatments reduce problem behavior, but then when we do an extinction challenge, we get higher levels of resurgence in our control condition, the dense short condition shown here. And we also look at the data typically as a proportion of baseline, because this focuses on the momentum question. And you can see the results are even more pronounced, much more resurgence in our control condition relative to our test condition. And this graph shows how well the BMT equation fit the data across all the participants in this study. What you see here are, this is the end of treatment. So these are the last 2 data points averaged across participants for our control condition, the black, and our test condition, the open circles. And then this is the extinction challenge. And what you see is fairly high levels of resurgence across participants across all 6 of the sessions during the extinction challenge, and considerably lower levels of resurgence in our lean lung or our test condition, treatment condition. And the overall results for this study is that the behavioral momentum theory informed treatment package reduced resurgence by 65% across participants. The BMT equation fit the data reasonably well in terms of predicting the outcomes. And the mean difference between the test and control conditions was statistically significant. In the final study that I'll discuss today, we examined the effects of adding discriminative stimuli, our MALT FCT treatment, to the BMT equation. And our working hypothesis in this line of research is that the use of discriminative stimulus, the stimulus context, using those during the extinction condition makes the extinction challenge more similar to our treatment condition, and thus we should get greater generalization. And this is based on the generalization decrement hypothesis that basically states that generalization from the original treatment context to the transfer context decreases as the similarity between the training and the transfer context decreases. So the more similar we can make our treatment and our transfer context, the greater generalization we should get. And the discriminative stimuli from MALT FCT help to increase the similarity between the original treatment context and the transfer context. And in particular, by presenting the S delta that signals that reinforcement is not available, that makes that extinction challenge very similar to the extinction component of our MALT FCT treatment. And so here is a case from that study. We did pre-training, and then we did our resurgence evaluation in novel contexts. And our contexts A, B, and C were differentiated by the colors of the lights in the room, the color of clothing that the therapists wore to make them very, very distinct. So in baseline, we had a fairly stable baseline in context A. We then introduce our MALT treatment, starting with 60 seconds of reinforcement, alternating with 60 seconds of reinforcement, 30 seconds of extinction, I'm sorry. And we get a nice reduction, increase in our FCRs. We then thin the schedule. In this case, we were able to do it very rapidly to 60 seconds of reinforcement, alternated with 240 seconds of extinction. And then we start 2 new baselines. We use variable interval schedules, very dense ones that are close to what our FR1 schedule in baseline. So the 2 contexts are very equivalent. We then introduce FCT, and the only difference between our 2 contexts is now in FCT, the individual is wearing the lanyard that signals reinforcement is available in context C, but not in context B, and FCT works really well in both contexts. See high rates of FCRs, low rates of destructive, basically 0 rates of destructive behavior. And then we go to our extinction challenge, where we remove reinforcement for the functional communication response. And the only difference between these 2 contexts are that in context C, we now have the therapist wear the red lanyard that signals the unavailability of reinforcement in context C, but not in context B. And so what you see as we go through these is that we get considerable resurgence of destructive behavior in context B, where the lanyard is not present, and no resurgence whatsoever in context C, where we signal that extinction is in place because this is very similar to our treatment condition that we did in pre-training. Another interesting finding that we saw with Kendrick was that when the extinction component was in place, we saw 0 levels of the functional communication response, meaning we got generalization of the functional communication training from our pre-training to here, where when we didn't have the lanyard present in context B, we essentially got a large extinction burst of the functional communication response. We also evaluated the model fits between the original BMT equation and one that included a parameter for modeling the effects of our discriminative stimuli. And this is similar to the one you saw before. So our treatment context is the open circles, control is the closed circles. These are the last 2 sessions of FCT across participants. And then this is the extinction challenge for our control condition in black and our test condition in open circles. And our original BMT equation does not predict very well. The line essentially, the 2 lines are right over each other in the middle of the data. But then when we use that parameter to scale the effects of the discriminative stimuli, we get much better predictions in our control condition, which is this dashed line, and for our test condition, which is this solid line. So MALT-FCT reduced resurgence by an average of 81%. We had significant differences in our conditions at the 0.01 level. And we believe this is better than any other BMT-informed relapse method that we've looked at or others have looked at. And our data fit the model much better when we included a parameter to account for the effects of the discriminative stimuli. All right, I will end there and we can go forward to the discussion.
Thank you. I think someone just put something in the Q&A up here. Yes. Someone asked if the lanyard signaling extinction was worn and had data collected for an extended time, would you eventually see research in that context as well?
We haven't done, I mean, we've done it for extended periods of time on a within subject basis, back sessions. So that we've done and had pretty good control. If we never had reinforcement occurring and having it occur for an extended period of time, I would say yes, we would typically call that spontaneous recovery rather than resurgence. But yes, I think you can use the lanyards kind of periodically over reasonable periods of time to help prevent resurgence, but you still have to have periods of reinforcement, and it is the alternation between reinforcement and the extinction components that discrimination between the two that help to prevent resurgence. But if you just had only extinction in place and only the lanyard over time, I would expect to see spontaneous recovery in that condition. Excellent question.
Someone asked, how can we ensure the lanyard is always facing the correct way? Because they gave the example when following a child, sometimes it tends to turn around. So how can we overcome that limitation?
We try to control that. The therapists work hard to do that. And then the other big thing is that we make sure that when we make a change from one red to green or green to red or blue to yellow or whatever the colors are, that we put that the card in the line of sight of the individual so that they see that change. And typically that works fairly well. The individuals that we have that don't discriminate well in a multiple schedule, we usually go, or even if you have somebody that is, we occasionally will have somebody that will, try to change the card themselves, and then you can have a struggle over the card. If that occurs, we'll go to what we call response restriction, which is what I showed in the video with Dylan, where basically the card is both the response card and it is also a discriminative stimuli. When it's present, it signals that reinforcement is available. When we put it away, it signals that reinforcement is unavailable. And so we go to response restriction if we have, have somebody that's really not coming under good control of the multiple schedule, or if they're doing things like, trying to sabotage and turn the cards themselves, and then getting into a tussle with a therapist over that sort of thing. But that's a minority of the individuals that we do that with.
Great. Someone asked, if we're using signaled reinforcement and extinction, how can we mitigate the behavioral contrast as opposed to average allocation of responding to the different conditions?
So behavioral contrast is much less likely to occur under how we typically do it in a clinic, where it's an FR1 schedule, in part because of what I talked about for the extinction burst, is that in a typical situation, we're signaling the availability of reinforcement, say with the green card, and during that time, reinforcement is available. So we see the individual exchanges the card. It's usually on an FR1 during that period. and then the reinforcer is available. So they switch to consuming the reinforcer because it's now available. And so we typically don't see behavioral contrast under that situation because they're doing the response one time, consuming the reinforcer. If the green card's still out, they'll emit the FCR and then go back to consuming the reinforcer. And so it's more, you'll typically see behavioral contrast more under a multiple schedule, under partial interval or partial schedules in general.
Great. Someone asks, is the reinforcer eliminated at any point? And if so, how often do you see a resurgence of behavior when eliminating the visual support, such as the lanyard or card schedule?
We typically, over time, try to extend the schedule, and we've worked with some individuals to move them toward more naturalistic signals. Sometimes if they're verbal behavior of just saying something's available, it's not available, or you need to wait, or I'm busy now. And it's one of those things where it's worth an empirical trial, and to do that over time. We had twins with autism and problem behavior where that occurred primarily around sharing of toys or things that they only had one of. And we started with the multiple schedule as we typically do it, and then went to a countdown timer and taught them both to set the countdown timer so that when one of them had a toy and the other one wanted to play with that toy, they could ask for it, and the other child could say, you need to wait. If they were told they need to wait, the child who asked for the toy could go in and set the timer for 10 minutes, and they would only have to wait 10 minutes until they had access to that toy. And that took a good long time to get from the multiple schedule to another multiple schedule, but one where there were several moving parts essentially. But yes, I think that's the long-term goal. With most of the individuals that we work with, we discharge them before that process starts, because we're with them over the short term, and they typically go back to another provider after that.
All right, we have two more questions. Someone asked, can you use a PEX icon in place of a color to overcome the effect of a child unable to discriminate the color?
Yeah, we've just gone to other colors typically, but yes, a PEX symbol can work. We have somebody in-house right now where we've gone to their communication device. And have used symbols on there. It's amazing. They're very, very small, and the individual is doing very well with that.
Okay, great. And then the last question, someone's asked, for clients that have excessive access to a reinforcer, such as an iPad, and you're attempting to limit it, would you suggest this type of procedure even with a child using PEX?
Yes, I think others have, the multiple schedules and this type of procedure have been used with individuals who are, consuming the reinforcer too often, and even if they don't have problem behavior. So the multiple schedule can be used to thin a reinforcement schedule. Typically, we do a combination of the multiple schedule and a chain schedule where during the S delta, where reinforcement's not available, they may need to complete a certain amount of work, so that we have sometimes where they basically have to entertain themselves during that period, or they have lesser preferred items available during the S Delta, not the functional reinforcer. And then at other times, they need to complete their school tasks or work tasks. And so we want to, kind of over time, adjust the schedules so that they mimic or comport with the child's home and school schedule, so that they're, other than having signals, they're doing things as similar to the other kids as possible.
Well, thank you so much, Dr. Fisher. We've loved having you. And we really appreciate your time sharing all your work with us.